Hello, everyone. I'm obviously not Clara MacKay. It's an honor to be here today among friends and new friends and colleagues. For those of you who don't know me, which is probably most of you in the room, my name is Phaedra Charlton. I am the Director of Communications and Marketing for the World Ovarian Cancer Coalition. Before I begin, I would like to mention that we have prepared an electronic information kit, and it's accessible by scanning the QR code that's on the screen behind me, but also on the rack cards on the tables. And we have no disclosures. So the World Ovarian Cancer Coalition, just to give a bit of background, was formed in 2016 and is a network of close to 200 patient advocacy organizations from around the world. And we believe that every woman with ovarian cancer deserves the best chance of survival and the best quality of life, no matter where she lives. Our partner organizations are located in every inhabited continent in 51 countries around the world, and they range from small kitchen table organizations of dedicated volunteers to large, relatively well-resourced organizations with corporate offices and staff. Our organizations are roughly evenly split between ovarian cancer, which is roughly a third. The other 2/3 are split between gynae cancer, women's health, or just pan cancer. And generally, the smaller, the less resource the setting, the more likely it is to be general or pan cancer. Now, every year on May 8th, we drive the World Ovarian Cancer Day campaign, which just this year reached over 100 million people through all of our partners, many of you in this room, so thank you. And then close to 28 million was reached just on our channels. And the theme for 2022 and the next 2 years is No Woman Left Behind. For us, this is more than just a slogan. It lives at the heart of what we do and is decidedly linked to our vision and mission. So right now I'm pleased to introduce Clara MacKay, our CEO, who is going to talk about our recent work in getting to that goal.
Thank you, Phaedra. So I am Clara MacKay, and I'm really delighted to be here today. And it's just, as Phaedra said, wonderful to see friends new and old, and to hear really the presentations today. It's just been, I think, just so interesting and enlightening, and I've enjoyed every minute of it. But to talk to our Every Woman study, so to say that ovarian cancer remains one of the most lethal of women's cancers. In higher income countries, survival rates range from 36 to 46% for 5-year survival, while in lower income countries, we know this figure is much lower. And as you will have seen if you've looked at some of the background materials that we've provided, the number of new cases globally of ovarian cancer will rise by 42% by 2040, and more shockingly, deaths will jump by over 50% in that same time frame. So if we do not change the status quo over the next 18 years, over 4 million women worldwide will die from this disease. So this is a pressing public health concern that requires urgent global action. However, it is especially significant that over 70% of women who are diagnosed with ovarian cancer live in low and middle income countries. And this is where the burden is heaviest and this is where the loss will be greatest felt. So our Access to Essential Medicines report released today highlights many of the very specific challenges that low and middle income countries face, including lack of access to data to support effective cancer control planning, fragile healthcare systems where often even the most basic treatments are not readily available. And when those treatments are available, many women face paying for them out of pocket, resulting in financial catastrophe, or actually what is more likely, women just not accessing treatment at all. But beyond healthcare systems, women in low and middle income countries routinely face other significant barriers to accessing treatment, including not being able to access or even afford transport to hospitals. So sometimes even when treatments are free at hospital sites, women cannot afford or access transport to travel to those sites. So the purpose of the Every Woman study is to provide much needed evidence about the experiences of women with ovarian cancer in these settings and the healthcare professionals that are dedicated to offering the best care possible. This data is vital if we are to influence national and global policymakers to take action to improve access to care and outcomes. So just a word about our partnership. We're just really proud to be working with our strategic advocacy partner, the International Gynecologic Cancer Society, on this project. With the concept of health equity embedded in the core of their work, a value that we at the Coalition share, we are able to bring together the clinical and patient voices in this one single project, opening up the possibilities for powerful advocacy work in the future so we can bridge the widening gap for women. The Every Woman study and the process by which we are implementing it will lay a foundation for stronger ties between clinicians and patients who together can be a commanding force for change. It is our hope that this study will not only benefit women with ovarian cancer, but that it will also act as an example of excellent practice for other patient research projects and evidence in all disease in underserved populations. So with that, I'm very pleased now to introduce Frances Reed, who is the program director at the World Ovarian Cancer Coalition and the lead on the Every Woman study. So Frances isn't here in person, but we have a video.
I'm delighted to be here today to talk to you about the Every Woman study at the IGCS Advocacy Day. The Every Woman study LMIC edition was adapted from our original study in 2018, which involved 1,531 women in 44 countries doing a survey online in 15 languages. And our results were published in the International Journal of Gynecological Cancer. It was about women's experiences of living with ovarian cancer. We came up with a set of common challenges that women face, from a lack of awareness of the disease and its symptoms, delays in diagnosis, both at the patient and clinician end, access to treatments and surgery, access to genetic testing, information and support needs, and a general lack of data. What we showed, though, was that each country varied in a nuanced way between what was most pressing for them. So, for example, women in the United States, whilst they know quite a bit about ovarian cancer, are somewhat slow to go to the doctor with those symptoms, and then the doctor is slow to act on them. In the UK, women know lots about ovarian cancer and they do go to the doctor, but not quickly enough. And in both cases, and in particular in the UK, doctors are then very slow at moving women through a diagnostic process. Japan is quite different. Women know very little about ovarian cancer, but when they are poorly, they go to the doctor quickly, and then the doctor acts quickly. So there's some 3 to 4 months difference in time to diagnosis between Japan and, say, the US. But in Japan, genetic testing is really poor compared to really good testing in the United States. So everywhere is different. It led us to develop the Global Ovarian Cancer Charter in 2020, and it helped us define some common goals and language between clinicians and advocates. And that's when we became strategic advocacy partners with IGCS. And we set about creating an authoritative evidence base, or taking this authoritative evidence base to start discussions with key stakeholders. Valuable information for our members. So in Canada, they actually adapted the study and did further in-depth work, and that's being used at the core of new major funding proposals. As you'll see, these are the countries who participated in 2018. They're mainly high-income countries, and that contrasts with where women live. 70% of women who have ovarian cancer in the world live in low and middle-income countries, yet we only had 5% of the original survey from those settings. It's important to fill this evidence gap because there are projected increases in mortality and incidence to the year 2040, And when you look at where those increases are, they're mainly, or the greatest burden will be in developing countries. Ovarian cancer, as we know, is really hard to diagnose and to treat, even in high-income countries. And in places like Africa, it is becoming an increasing issue already, and that will only get much worse. So now is the time to act and find ways to improve outcomes. So our objective is to fill that evidence gap. We want international data, global data, and we want national data. So the study's been designed so countries can use their data at a country level. We hope there'll be publications. We'll provide comparability between countries. And we hope patients and their clinicians will begin to work together more to promote advocacy efforts and foster new or develop existing relationships with local NGOs. Really develop a collaborative voice. These are the areas of questioning in the study. As you'll see, they're really quite wide-ranging. So they really cover what has been most important for the women. Currently, we have 24 countries actively participating with 125 sites, a really good mix of geographic locations and income status. It's a hugely complex task to get this study undertaken. We're doing it in 31 different languages. Women can do it by a secure email link, a secure WhatsApp link. They can be interviewed in the hospital by a person, or they can fill in a paper survey in the hospital. So it's all been run through the hospitals, and this is because we need to up the participant rate. The doctors are providing details on the type and stage of ovarian cancer, surgery, drugs and genetic testing, and the country lead clinicians are providing a video interview and in-depth survey on the state of current ovarian cancer care in their country. So we have these countries now collecting data, just about. Malaysia, well, they are, Brazil, Kenya, Argentina and Jamaica. And we've got some data already assessed, women assessed, those declared eligible, and then data collected. And you can see we're beginning to get little bits of information through our live data collection. So on average, the median age is about 54 years. The youngest is 18, the oldest 78. Nearly 2/3 are employed at the time of diagnosis. Really good spread of income levels in terms of the countries that they're in. High-grade serous, the most common form, then endometrioid, and a variety of stage on diagnosis. So we can get live glimpses as we go through the study, and data collection goes on till June next year. Been loads of challenges getting this underway. Ensuring participating centres reflect the variety of care, dealing with all the languages, making sure those countries and centres with the lowest resource and the patients with the lowest resource can participate. And that means we have to vary sometimes our approach in different countries. And we've had issues with delays because of COVID, ethics approvals, just because of the timescale, natural timescales of committee meetings. We've had local unrest, forcing staff into hiding. We've had emigration of key personnel. It's a huge challenge bringing all of this together. But it's really, really important, because if you think here, right at the middle, we have access to medicines, diagnostic and surgery, and then possibly even clinical research. We hope those would be available to everybody. We know in lower middle income countries, often not. But when you layer around that the financial barriers, the geographic barriers, cultural barriers and health literacy, you find that for every single woman there is a different route in, and it depends how far she gets through that as to whether she achieves good diagnostics, surgery and medicine. And it's really important to have this data to understand what is happening. I mentioned it was a very complex task. 24 countries, 125 sites, 31 languages. Most countries need national ethics approval and local ethics approval. Fees may or may not be payable. Some translations done up front, some done later. And teams have different levels of resources and skills. So it's a huge project and still in the very busy phase of it. But we've had some really good feedback early on. This is the Malaysian team. On the left, they were interviewing the very first, or getting consent from the very first patient. And here they are on the right. They were celebrating the fact that they'd done 25 interviews. So they're absolutely thrilled with that and thrilled with their progress so far. Early outcomes. There is a new support group, Ovarian Cancer Malaysia, set up directly because of the study. We've had development of new patient information in hospitals and countries where none has ever existed before. We've had reports of better clinician-woman interaction as a result of doing the surveys. And we've had reports of the clinicians actually now becoming involved in advocacy work on issues such as access to medicines, where they'd previously not even realised that work was being done in their country on these issues. Where might it lead? Well, we hope maybe a grants programme to help overcome country-specific challenges, informed advocacy routes depending on the location. So it's not up to us to say what your particular issues are, but countries involved will know what their own issues are and decide what is most important for them. It'll give greater context for discussions about access to medicines and standard of care debates. Some countries are planning to continue collecting data. Some are doing even more in-depth work after they collect the initial data, such as in India. We may have new countries participate, and there's even been talk of adapting it for other gynecological cancers. But that's all in the future. We've got a lot to get through in the meantime. None of it would have been possible without the most fantastic oversight committee and our team of country leads who are working incredibly hard to make this happen. Sometimes it's the first in-country collaboration that's been done. They're having to do lots of new things, they're having to organise a lot of things, having to check a lot of things, but we really hope that come the end of this, they will have some data that will really help them and those they're involved with take steps forward to improve care. And on that note, I'd like to say thank you very much for listening.
Thank you, and thank you, Frances, for, as always, an amazing presentation. So I think, as Frances has highlighted, conducting a study on this scale is complex and certainly not without its challenges. But it's often the work that isn't easy that is the work that is most needed. And Frances provided an excellent overview of the study, and we're delighted that data collection has started in several locations already. But throughout the process of the study, we have just been constantly amazed at the enthusiasm and dedication of not only the patient advocates, but of the clinicians who were involved even in the face of extremely limited resource and the ongoing pandemic. As part of the Every Woman study, we have interviewed lead clinicians in participating countries, first to get their perspective, but also to capture the missing women from the study. But today we wanted to share with you experiences from some of these clinicians and advocates to provide further insight into the challenges that they and that the women that they care for face. So we have some more video for you.
I am Florence Anol. I am a gynecologist. I'm member of the Oversight Committee of the Every Woman Study, Low and Middle Income Edition. And also I'm the country leader of the project from Argentina, the second largest country in South America. First, I would like to highlight that we are working as a team with the 10 referral centers in my country, and I'm proud of it, but it's a large country, and you know that's a complex job. So the national inequality is a big challenge, reaching out all our patients and even our clinicians. We have no centralized care and no proper surgical training. Nowadays, big distances, poor communication, and the lack of a proper training are a setback. Regarding patients from not being able to reach the hospital due to transportation issues to the economic impossibility to afford surgical or chemotherapy treatments, they have limited or even non-existent access to diagnosis, treatment, and care in my setting. In the other hand, about clinicians, I think that our mission is focused on coordinating efforts and raising awareness among our colleagues, among us, about the necessity of quantifying the experience of all women from such different realities living in the same country. This is in order to foster our net, which I think is the most important tool for improving our performance and strategies for patient care. From another point of view, me as a clinician, I've gained experience and understanding through the patients themselves, speaking about the impact of the disease and their quality of lives, and their very limited access to information about their illness. And I've also learned through my colleagues, through their realities and their effort in the daily practice. Teamwork now is proving to be a very challenging task, a very big task, and the Every Woman study is the first study in our region connecting clinicians and women with ovarian cancer all over the country. Also, it is helping us to improve and foster our communication, because in our field, as in many others, change can only happen when it is based on evidence. In this line, reaching women experiences as they move from pre-diagnosis to post-treatment and the quality of life throughout will serve as a guide to identify particular local challenges and develop regional and local strategies for authentic and constructive solutions. On the other hand, creating a national database, a cancer registry, something that we're lacking of, will be a cornerstone for further regional research projects that will probably support new and more advanced public health policies. Speaking about the hopes for our women, I think that achieving this goal will be the key to closing the wide gap in care, equity, and inclusiveness for those bearing the heaviest burden of the disease. Only when we quantify the experiences of those women living in underserved settings shall we be able to see the way forward for change. Our goal is to improve early access to health system, to decrease the waiting time to get to the specialist, and also to provide continuous and better support, standing by the patients throughout the whole path of the illness. This is a groundbreaking study, and it will give voice to the problems and opportunities of the women themselves. In a way, they are the ones that will help create this change in their lives.
Often physicians are seen in a purely clinical light, and we forget that there is a human being behind the stethoscope who wants better for their patients. Renee Perea is one such doctor who will tell you about the personal price he pays for caring for women with ovarian cancer in Colombia.
My name is Renee Pareja. I'm a gynecologic oncologist. Around 20 years ago, in Colombia, I was formed at the Instituto Nacional de Cancerología in Bogotá, but my workplace is located in Medellin, Colombia. I work in two private institutions working for the public health system, as usually happens in my country. The private institutions usually work for the public health system. Eventually, I became friend from several of them. They're friends. They're my friends. We go to their houses. They came to here. Depends of the type of relationship that you can establish. It's more easy if the patients, there is a, I don't know how to explain this well. It's a kind of click. You may click with some kind of patients, and those who respond well to believe in the treatment, to trust in the doctor recommendations, they'll go well. And of course, I have lost most of them. I remember them by their name. I visited them in their houses. Right. I have accompanied them at the end of life, most of them. In some cases, I still have the contact in my WhatsApp with their husbands. And I used to talk with their husband. They, in the day of the doctor, they send messages to me, their congratulations, kind of things like that. But those are the most difficult patients, because when you are seeing the patient by first time, you have, those lady has a 75% chance of dying of the disease. but she doesn't know that. The family doesn't know that. Nobody doesn't know that I really know. And this is sad. This is sad because at the end, the statistic is the same. You lost 3 or 4. And this is a hard way to walk on. It's a hard way as a patient and as a doctor.
Unfortunately for many, getting to that first meeting or any meeting with a doctor is an insurmountable challenge. NIAC explains how geography is sometimes the greatest barrier to access and how some of those challenges might be overcome.
My name is Ngọc Phan. I'm a GYN oncologist in Vietnam. I graduated from OB/GY residency in 2014. In my practice, I saw a lot of patients who come from remote areas. They are very poor and they don't have enough condition to access the internet, the information, as well as the transportation there is quite difficult to them. And that's why they usually come to us with very advanced symptoms. And many cases are that they lost to follow up. It's painful that we can cure their disease, but we cannot cure their surveillance. They, after surgery or after one course of chemotherapy treatment, they gave up and lots of follow-up. That's very difficult to treat those situations because they are living in remote areas and they have their languages. I and my colleagues, we are trying to learn their language to have a better communication with them. Our goal is no one left behind. In our institute, we have a online appointment. So the patient during the pandemic, the patient should learn how to access the internet so they can easier to choose a day with their clinicians as well as the day they receive their treatment. So it's more convenient. And telephone appointment, yes, they can call their service, health services to receive recommendations as well as their information.
Even after getting to that meeting and getting a diagnosis, the availability of information and support to women and their families can be poor or non-existent. Instead of spending time together, loved ones are forced to spend their time searching for information on treatments, compounded by the burden of having to pay out of pocket for treatments available in many other countries. Rafael Sadnan Adel contributed to our Access to Essential Medicines report, and Every Woman Study Oversight Committee member explains.
I'm Rafi Sadnan Adel. I'm the head of media and external relations here in the world's largest nonprofit organizations titled BRAC. And in person, I'm a former journalist as well. And in Bangladesh, I am the founder chairperson of CancerBD.net, which is the first ever cancer awareness web portal, which is totally narrated in our native language, Bengali. And I would like to share a few experiences with you all so that you can easily connect why CancerBD.net is important here in Bangladesh. Back in 2000, 10, my mother was first diagnosed with ovarian cancer, and she has suffered around 3.5 years in this type of cancer. But unfortunately, we lose her in 2014, 31st May. In this journey, I have suffered a lot in terms of informations, in terms of financial capabilities, because here, that time Bangladesh is a lower income country. Right now it's a mid-income country, but that time a person from a middle income country has to struggle a lot for this sort of treatment, because as you all know, the chemotherapy drugs are very expensive here in Bangladesh, as well in South Asia. And apart from that, I have suffered a lot in getting informations, because all the informations are based on the West countries and in English as well. So to connect, to know more about cancer was a very tough task for me for the first time as well. So I have got an idea that we need to have a platform where we will get more informations about cancer, and most importantly that informations should be in Bengali. Then in 2014 we have started cancerbeti.net, which is a Bengali language cancer awareness site. And we have tried our best to get authentic information from the other English-based websites, and we just translated those and get cross-checked by the current physicians, oncologists, and put that into our website. That was our first journey. And after passing 2 or 4 years, we get to know that it's in Bangladesh, the social media platforms are getting very powerful. Even the government counted these platforms with a very high value, and all around the peoples are browsing all the informations and through the social media, and they got hugely involved in these areas like Facebook, Twitter, YouTube. Then we have started using these sort of platforms to disseminate our informations, cancer awareness informations there. And this year, after the 8 years journey, we have taken a 5 years plan, and we have changed a little bit our slogans. Right now, our slogans is we prevent cancer through communications, because we do strongly believe that the countries like us, the countries of South Asian countries, need to focus on one thing, that is early detection, because only early detection can save us from the higher expenditure of treatment in cancer. So we are focusing on early detection through all the communications channels by our initiative cancerbeti.net.
But even when women can get to the doctor or their hospital and find the information they need, other challenges remain, as Dr. Pariyar from Nepal explains.
I'm Jitendra Pariyar. I'm a gyne-oncologist serving in Civil Service Hospital, and I'm also attached to National Academy of Medical Sciences, which runs post-graduation and fellowship program. And I'm the professor in Obs-Gyne, taking care of gyne-oncology as well. And I'm the mentor for International Gyne Cancer Society fellowship program, Nepal site. So as per my work, I'm based in Kathmandu, which is the capital city of Nepal. And I'm a clinician and academician. And as a professional, I spend around 70% of my time catering most of my services to cancer patients, apart from general hospital services. So since we had the diagnosis, we wanted to give chemotherapy, but somehow patient party, especially the husband wanted alternative medicine. We knew that this was a chemosensitive tumor, but they heard about alternative medicine, herbal medicines, which they thought was better than chemotherapy, because chemotherapy, they had seen some of our patients with alopecia and weakness, so they refused chemotherapy. And this was such a sad case that we, like all of our team members, felt from gyne-oncology, from clinical oncology, we knew that she would do well with chemotherapy, because germ cell ovarian tumor being very chemosensitive, and she was young. But the patient and her family denied chemotherapy. Hearing and seeing that the chemotherapy was associated with some of the side effects. So this was a very sad case, and we kind of lost her. We have not met her.
But there is hope. The Every Woman study is already inspiring change and opening doors to new possibilities, from the first ever ovarian cancer patient group in Malaysia, local advocates successfully working with the National Health Ministry in Malawi, to energizing Aisha Mustafa, our lead clinician in Nigeria.
My name is Aisha Mustafa. I'm a medical doctor, a consultant obstetrician and gynecologist, specifically working in the gynecology oncology unit at Ahmadu Bello University Teaching Hospital in Zaria, Kaduna State, northwestern Nigeria. I basically work in gyne-oncology, and I see only gyne-oncology patients. And I'm actually the country lead for the Every Woman study in Nigeria, and I'm super excited participating in the Every Woman study for low and middle income countries. The Every Woman study for me, being on the team, is actually, shall I say, I feel honored to be part of the study. And why I'm actually excited is because this is the first time we in Nigeria are conducting a multi-center, specifically a 12-site study, prospectively recruiting women with ovarian cancers in the 6 geopolitical zones of the country. And with this will help us actually identify the key challenges these women are facing and actually document them, because some of us know the challenges, but these have not been documented in such large scale. And apart from identifying these challenges, it will also help us to provide the opportunities on how we can improve the overall survival of these women by actually getting policy statements from such research. That's for us generally. Then to me personally, I'm actually excited participating in this study because it is actually improving my own capabilities in research. I have not participated in such study before, and I am seeing how this is going on from the beginning through when we started almost a year ago. And it has actually opened my mind to future possibilities, future collaborative researches among the members of the 12 sites, participating sites, and also the international community and even beyond. So this is actually helping my own research capability. And I also see us collaborating for the future after providing a database for ovarian cancer patients. And of course, with their permission, we'll be able to call them up and probably do even more research based on the number, on the women that we have recruited for this study. I actually believe that this study will change the future for ovarian cancer care in Nigerian women, and also for us, the researchers that are participating in it.
So as you've heard this afternoon, even though we've just begun to capture the stories of women with ovarian cancer in low and middle income countries, a compelling prologue is emerging for the narrative to come. The Access to Essential Medicines report outlines some of the challenges in low and middle income countries with the unavailability of effective and inexpensive workhorse medications leading to needless suffering. A paucity of data impedes advocates who need evidence-based solutions to be the most effective. And governments have little basis from which to create national cancer control plans. We anticipate that the final Every Woman Study report will echo many of the challenges and issues revealed here this afternoon. There is so much more to learn from the women themselves about their specific circumstances and barriers, because only they can fully tell their story and tell us where we've been most impactful advocating for change. While we look forward to the results so we can work on a global level, we are excited that the data will be robust enough so that each country will be empowered to navigate the path to change themselves, to improve the experiences of their mothers, sisters, wives, friends, and colleagues in their own communities, building a more robust international advocacy movement. It is our hope, armed with the data we are gathering, that we can, working together at every level, get to a world where no woman, no matter where she lives, is left behind. And now open it up to questions. Thank you.
Well, I think you have to be congratulated. I've already said to Frances she needs to write a dossier on all the challenges and how she's overcome them, because I think there's so much to be learned from just the process that you've gone through. It was lovely to hear about the education that the physicians and the country leads feel that they're getting, and realizing what they can then do is also very important. And I think it shows that research is not all about investigational medicinal product clinical trials. You can learn so much from just collecting data to start with, and then the questions that come from that. So I guess my next question is, when can we start the other gynecological cancers?
Very, very good question. So we're very focused on this study right now, which I can't recall if we mentioned in our presentation. We're hoping data collection will be complete by June 2023. It'll take a little time to sort of pull it together in publications, but we're hopeful by September 2023 we'll start to be able to share results at important meetings like this meeting. But we also know that many of the clinicians that we're talking to are already talking about extending the study and opening it up to a wider group of gynecologic cancer patients, so which is something we would wholeheartedly support. I think, as Phaedra highlighted in her introduction, we work with advocacy, about 200 advocacy groups. About a third of those are ovarian cancer, but the other 2/3 cover other gynecological cancers, women's health, women's cancer. So we really want to, our focus is ovarian, but we want to work in a way that strategically and that supports all of our member organizations in all of their work. So I'd say, I feel personally very optimistic that this work will carry on beyond the kind of end of the formal study and will be extended beyond ovarian cancer.
Well, certainly anything that we can do to help.
Okay. We already have an amazing partnership. So, I think building on that is, I sort of feel the sky's the limit. I just think there's so much that we can do together. And I think we've learned, working with IGCS and working with our patient advocates and patient advocacy organization, there's some transformational moments that occur that makes you realize just the sheer power of that combination of advocacy and clinical, clinicians and researchers. It's something that is a delight to be part of, and hope to see much more of that. And I do think it is, about collaboration and partnerships. I really, together, for sure, we can move mountains. And sometimes I think we all are sort of in our lane with our head down, focusing on our own priority, and occasionally I think we should get in each other's lane and, kind of help each other along a bit. So probably the final thing to say is in terms of the Every Woman study in low and middle income countries and the access to medicines work that we talked about as well. And again, to repeat, Phaedra, if you go to our website, or I think we've left some information on tables, you can quickly access this presentation as well. But just to say, when we pull it together, our ultimate goal is that ovarian cancer becomes recognized as a global priority. And we feel that this work is an important step forward towards that. So the coalition will take this data, a global data set, and we will be, actively talking to and lobbying global health organizations like the World Health Organization and other agencies that have influence over global health priorities. But I think the beauty of it is that we also are able to give back and work with, at country level, the data sets that will enable clinicians and patients in those countries to actively advocate for change at a national level. So again, it feels like it's a powerful synergy, and I think, I think it was Saisha that said it will change ovarian cancer. It will change, this will drive important change.